Mm. I think the time is now. We can start, if you allow me. First of all, Assalamu alaikum wa rahmatullah. Good evening and good afternoon, good morning to everyone they are attending this meeting. Uh, First of all, today we are having two sessions. One is posterior segment. It will cover some talks about the experience in treatment of DME by a steroid mainly, and maybe we can pass through the other methods of treatment of diabetic macular edema. And in the first sessions, we are going to have one of eminent speakers. I'm proud to have him them today. My dear friends, Dr. Prasan Rao, he will be the first speaker. Dr. Prasan Rao, he is an FRCS UK MS ophthalmic, also DFNB, FCBS, DO, DOMS, MBBS, medical director of and specialist ophthalmologist, pituitary surgeon, Midcare Eye Center in Dubai Hospital, in Dubai, UAE. And then we are going to have my dear friend is Dr. Fahad Kuhail, and he is going to have also Dr. Fahad, he is of RCS, consultant ophthalmic surgeon, Royal Hampshire Hospital, England. I think we will start with Fahad first, then we will have Dr. Brasan. This is for the first, and then the second session, it will be an anterior segment symposium. And when we will start, we will introduce our speaker and panelist. Dr. Fahad, he will give a talk.
Are you happy for me to share my screen, Mohammed?
Yes, you can start, please. Dr. Fahad, he will give his talk about steroid and the treatment burden in diabetic macular edema, lesson from COVID pandemic. Dr. Fahad, the mic with you, please.
Thank you. I'm just going to try and go into my talk again. Can everybody see my slides?
Yes, please.
So thank you, Mohammed, for asking me to give this talk today. Essentially, the pandemic, if you guys remember, was a bit of a terrifying time. Obviously, a year on, now that we have the vaccines, we're much more comfortable working in a COVID world. And in fact, we're moving forward to coping in a post-COVID world and how we were going to manage our patients. But at the time, it was quite scary. There was a lot of unknowns. And if you guys remember, in March 2020 in the UK, the whole country was in lockdown from the 16th of March 2020. What did that mean for the hospitalized service? Well, essentially it meant all elective procedures and outpatient appointments were deferred unless they were deemed to be clinically urgent. At the time, the Royal College of Ophthalmologists in the UK was very helpful in rapidly issuing guidelines to help hospitalized services prioritize their patients in this rapidly changing landscape with too many unknowns. One of the casualties of the lockdown were our diabetic macular edema patients, because in March 2021, when the Royal College of Ophthalmology published its medical retina management plans during COVID, it correctly prioritized wet AMD patients. And patients with diabetic macular edema were automatically deferred for 4 months, with the only exceptions, those eyes with pre-proliferative retinopathy, so severe non-proliferative retinopathy or active proliferative diabetic retinopathy. Obviously, with those eyes, it was important that you continue with their anti-VEGF because there's a high risk that their proliferative disease might progress with potentially devastating sight-threatening changes. And during lockdown, I was still working, partly from home, partly in the hospital, and I would see urgently any case of diabetic macular edema who called casualty or my team with vision impairment, and we would treat them. And I therefore treated a few diabetic macular edemas during that first lockdown. However, the first lockdown actually continued for quite a while and wasn't actually lifted to June of 2020, where hospitalized services entered the recovery phase. And due to the understandable fear amongst the public, very few patients were happy to actually attend the hospitalized service for face-to-face interaction. In fact, the majority of the disease activity assessments were performed virtually in an arena in the north of the city. So because lockdown meant no concerts were happening, no football games were happening, we were able as a hospital to utilize some of these big areas with wide open spaces to assess patients. And we set up a big imaging hub in the north of the city where patients would get a vision, pressure, dilatation, 7-field color fundus photography, where you would, using a camera, take a photograph of the disc and macula and of the posterior pole, or would get an Optos wide field color photograph with OCT scans. And then we would report on those during the week remotely, sometimes from at work, sometimes from at home, because I'm able to access those images via the internet, make treatment decisions. And because of the peculiarity in the UK, we can only use steroids in pseudophakic patients, but we can use, obviously, if they're phakic, we can only use anti-VEGF. And for DMO patients, if they were pseudophakic, we discussed with the patient over the phone whether they wanted to consider a short-term steroid like Ozurdex or a long-term steroid as like Iluvien, if they meet NICE guidance, to treat that DMO recurrence. If they were phakic, we just prescribed them with fixed 8-weekly dosing with Eylea. NICE, which is our National Institute for Clinical Excellence, limits the license that the drug has. So the Ozurdex license in Europe is indicated for the treatment of adult patients with vision impairment due to diabetic macular edema who are pseudophakic. But the European license also allows you to treat phakic patients if they're considered insufficiently responsive or unsuitable for non-corticosteroid therapy. So for example, somebody who doesn't respond to anti-VEGF or cannot cope with the treatment burden that you need for the best outcome with anti-VEGF. The license in Europe would allow you to consider Ozurdex. However, in the UK, we were limited in that we could only consider patients who are pseudophakic and who are insufficiently responsive to non-corticosteroid treatment or such treatment as unsuitable. And because we were in the middle of a pandemic, I was very keen that those patients who were pseudophakic with active DMO back in June were offered at least the option of offering them a short-acting steroid was considered. And a lot of patients took up that opportunity because it meant that they could have one Ozurdex injection, which would hopefully have a duration of 3 to 4 months. And they'd have to just be seen one more time for a safety check. And that could be done in a non-face-to-face environment where social distancing could be maintained. And a lot of patients did take up that as an option. Because of this talk, I also looked at the eyes that I've treated with Iluvien, and I've got around 42 patients who are currently alive in whom I've injected an Iluvien implant. And again, during that lockdown, only 5 of those 42 eyes actually required treatment back in June. So again, having a longer acting steroid, which was delivering steroid to the eye and delivering treatment over a longer duration of treatment, over a long duration of time, only few of those eyes actually came to harm because of lockdown. The vast majority, their disease control was maintained even with the lockdown. So although it's quite a short talk, going back to the actual title, steroids and treatment burden in DMO, for this pandemic, steroids were really helpful because either if my patient had a long-acting Iluvien, they avoided additional treatment during that lockdown, or if they were pseudophakic, not previously treated with Iluvien, and that had recurrent active DMO when services reopened, I was happy to offer them a shorter acting steroid agent such as Ozurdex, because again, there was a lot of fear. There was a lot of unknown at that time. We had no vaccine, and therefore patients were very keen to be considered for treatments that had a longer duration of action than anti-VEGF. And I have to say, now that we've, 6 months, 9 months down the line, now that we have the vaccine, most of my patients have done really, really well. So I've had no real duty of candor. So I've had no patients really come to severe loss of vision because of this lockdown. I've been able to, those patients who wanted to re-engage with the hospitalized service, we've been either been able to retreat them either with anti-VEGF or short-acting or even long-acting steroid. And I'm really proud to think that despite the upheaval that the lockdown created and the deferral of those patients, I'm really happy to say, as of June 2021, a lot of my patients are doing well with no cases really coming to real harm. And I think the ability in the UK to use virtual clinics, I've got lots of allied health professionals to help me report on my patients, and the variety of treatments that I have available to me, anti-VEGF, Ozurdex, and Iluvien to treat my diabetic macular edema patients, I'm really pleased to say we've been managing to avoid loss of vision and permanent harm despite the upheaval. I will end there. Are there any questions, Mohammed? Mohammed, you're on mute.
Thank you very much, Fahad, for this your experience, showing your experience during the pandemic of COVID and the role of steroid in managing of diabetic macular edema and prevent the deterioration actually in a patient vision during this pandemic, and also the minimize the time and exposure of these patients during the pandemic. There is some certain point I want just to ask, and I want to ask also dear colleagues, if there is any question, they can send their question through question and answer, and we'll give the answer, and they can just send it to and point it to which doctor they want to ask. Also, if someone who wants to also to participate with us live, he can raise his hand, and we are going to give him a mic to talk and discuss with us. My question, Fahad, you mentioned something, certain point that during the time of pandemic, you give only the steroid injection as in United Kingdom or British as in only on those pseudophakic. Is that information? And you tell only in pseudophakic without, I think they can be the first choice, you mean? Or if they are a phakic and there is no response, then you can go also for this. I want to clarify this point just.
Yeah, so in the UK, I think it's important. So in the UK, unfortunately, we are restricted to using short or long-acting steroid, either Ozurdex or Iluvien, in pseudophakic eyes. We cannot use them in phakic eyes. So, Ozurdex
you cannot use it at all, or you can use it insert.
Cannot use it at all.
Even if there is a no response?
Even if there's no response. I have to use off-label triamcinolone, and I have to make a personal request from the funding body for the region to get Ozurdex or Iluvien if I want it. I cannot just prescribe. However, Ozurdex was a lifesaver come June, because it meant that those pseudophakic eyes that had recurrent DMO, instead of giving them 3 to 4 Eylea injections, I was able to give them one Ozurdex, see them at 6 weeks for a pressure check, and then see them at 4 months for a disease activity assessment. And patients, it was great because patients were scared of using public transport. They're having to use their relatives to drive them to hospital. Anything that we could do to give them similar outcomes but reduce hospital visits, they embrace. What was great about my Iluvien treated eyes, of the 42 eyes that had Iluvien that were still alive, only 10% needed further treatment back in June.
In
so
1 year,
again, so after lockdown. So in June 2020, only 5 of my 42 Iluvien eyes needed any further therapy. The others, if they needed retreatment, may have happened at a later date, but having Olivin on board and having that continuous delivery of medication maintained their disease control. However, I want to clarify that the UAE or in the Middle East, you follow the European license, where if you have a patient with diabetic macular edema and is pseudophakic, you can treat them with Ozurdex. But if they're phakic, you can also consider Ozurdex if they're insufficiently responsive or anti-VEGF is unsuitable. And who is insufficient responsive, we are aware of. So patients where they're getting less than 5-letter gain in vision or less than a 20% reduction in central retinal thickness, we can say insufficient response to anti-VEGF. But who's unsuitable to anti-VEGF? It might be your pregnant patient, your vitrectomized patient, your patient with a heart attack and stroke, but also I'd argue your unsuitable patient is that patient who is unable to maintain the treatment, the intensive treatment regimen that anti-VEGF requires to get the best vision outcomes. So if I said to my patient, actually, if you want Eylea, you will have to get I'll have to give you 3 anti-VEGF injections over the next 6 months. Or I might be able to give you 1.5. Because that patient's unable to maintain that course of 3 injections, they're unsuitable for anti-VEGF, but they're more comfortable to consider Ozurdex. And even though I
Even
warn
they
them of
are a
the,
phakic.
even if they are phakic, I'm talking about the Middle East here.
Okay.
Talking about the Middle East here.
Okay, but
And
I have to. Okay, so
and
sorry.
what's interesting, even when I warn them that there's 1 in 3, they may need IOP lowering drops. For them, the reduced hospital visits, the reduced treatment burden is worth it, even if they need to take drops to control the pressure.
Thank you very much, Fahad. I think I have only one comment, and I will ask Prasan if there is any comment before that. I think there is even in Europe, some people, they are using us even as a first line of treatment. I mean, as a first line of treatment, and they are in aphakic patients. There is a study, I think, in Spain about this one. I
Yes.
don't remember.
Yes.
So, I mean, maybe this restriction more maybe in UK and not in Europe in general, right? I think like.
I think that is correct. If I was in the Middle East or in Europe, I would be using Ozurdex much more first line. The caveats that I've mentioned is applicable to the UK population only.
Okay. Fahad, sorry, Prasan, if there is any comments before we move to your talks, please.
I have one comment, please. One question.
Yes, of course.
Yeah, go ahead, Dr. Khalid.
Thank you, Dr. Fahad. How many times or how frequent can you repeat the Ozurdex injections in patients with diabetic macular edema?
As
an upper limit for the injections?
No, there's no upper limit. You can give as many as you can. So in the MEAD study, they needed on average about 6 to, I think, 8 injection over a 3-year period. In my own care, if a patient needs multiple Ozurdex injections, at that time, I'll probably start counseling them about considering a longer acting agent. But no, there's no limit, so like Olivin, but there's actually no limit in giving multiple Ozurdex injections if that's what you feel is in the patient's best interest.
Okay, so as we are running behind the time, yeah, Prasan, if you have any comment.
Can I start? No.
Oh, it's okay. So
Can
now yeah, please. Now I introduce my dear friend Prasan, and he will give a talk about dexamethasone implant in ischemic RVO and DME patients. Prasan.
At the outset, let me thank Dr. Amri. Are my slides seen and am I audible?
Yeah, everything is clear. But yes, go ahead, please.
Okay. So I'm just going to share 3 cases, and these are 3 challenging cases where I've used Ozurdex to help achieve good vision in my patients. So the first 2 cases are related to the ischemic retinal vein occlusion. And the reason I chose ischemic retinal vein occlusion because these are the eyes which are generally excluded from the anti-VEGF trials and also from the trials involving the vein occlusion study. So if you look at Bravo, Cruz, Copernicus, Galileo, and Vibrant, we don't have much information about anti-VEGF usage in ischemic vein occlusion. So this is the first case. It's a 56-year-old lady with reduced vision in the left eye in 2018. She's a known diabetic and hypertensive. and the left eye is pseudophakic with a posterior chamber intraocular lens. So she presented to me on 25th of June 2018 with a visual acuity of 0.05. If you look at the optic nerve looks fine. You can see this gross, the ischemic retinal vein occlusion, extensive hemorrhage, thickening in the retina. This is an artifact from the spectralis multicolor image. If you look at the OCT, you can see this gross thickening in the macular area to an extent that there was a lot of hyperreflectivity in the inner layers, which are obscuring the visualization of the outer layers of the retina and even the RPE. So we had two options here to discuss with her the use of anti-VEGF or to use dexamethasone. Now, she was a patient who was quite reluctant to come and take multiple injections. So we had a discussion with her daughter and the patient as well. And finally, we decided to give her an injection of Ozurdex. So this is, she's treatment naive. She's not had any anti-VEGF injections. And we decided to treat her with Ozurdex. That's why I said the case as going solo, using only Ozurdex. So this is 3 months post dexamethasone implant. Her visual acuity was still 0.05. But if you look at the colored image, you can see this resolution of the hemorrhage. You can see the sclerosed vessel very clearly. There's occurrence of these cotton wool spots. And if you look at the thickening of the retina had reduced, though it is still persistent. And now you can start visualizing the outer retinal layers. You can see some hyperreflectivity in the RPE as well. You can see multiple areas of intraretinal edema as well, and there was no subretinal fluid. We decided to continue with the injection. So this is 3 months post her second injection, almost 6 months after she followed up. The visual acuity improved to 0.1, not so much appreciable by the patient, but however, on Snellen's acuity, you could see there was an improvement there. This is a color fundus photograph. If you look at that, there's significant resolution of the hemorrhages. The cotton wool spots still persisted. And you can see this RPE change happening, atrophy happening in the macular area, which is pretty common in ischemic patients and those having long-standing macular edema. Here you can see the near normalization of the foveal contour. There was presence of intraretinal edema on either side of the macula. You can also appreciate the RPE changes, the hyperreflectivity in the RPE, indicating the RPE disturbance secondary to the macular edema. This is 5 months after the second injection, at which point of time she had this massive recurrence. Now, as we all know, most of the time, clinically, when we look at dexamethasone, the efficacy is between 3.5 to 4 months. And at 5 months, she did have a recurrence, and we decided to do another injection of dexamethasone. So this is 6 weeks post dexamethasone, the third injection. A vision is 0.1. You can see this RPE atrophic change here, significant resolution of all the hemorrhages, cotton wool spots here. You can just appreciate the sclerosed vessels. Fortunately, there were no neovascularization of the disc or elsewhere. You can also see this near normalization of the foveal contour and a few interretinal cysts in the perifoveal area. This is 5 months post dexamethasone implant number 3. Again, as I mentioned, usually at 4 months, they will have this recurrence. So this is where the recurrence occurred. Vision was almost the same, didn't change much. And we decided to continue with the injection. So this is 2 months post the fourth injection. You can see there's near normalization of the foveal contour, very minimal subretinal fluid. Fortunately, she didn't have any neovascularization seen in the retina. So we continued with the dexamethasone as and when she had her recurrences. And this is a macular photograph. You can appreciate the sclerosed vessels in the upper part. The upper part of the macula is grossly ischemic. And you can see these collaterals which are developing on the side as well. Again, this is 1 month after the injection, the vision improved to 0.2 partial. And this is how our OCT looked like. This is 1 month post her sixth injection, the vision was 0.2. So this is in August 2020, almost 2 months, 2 years after she followed up. And she had about 6 injections in this time period. This is a last follow-up. Visual acuity was 0.3 partial with near normalization, almost a normal foveal contour with minimal intraretinal fluid. Fortunately, there were no new vessels present. So in this case, the take-home message is approximately 15% of BRO patients are ischemic, and 15% of these patients might convert from non-ischemic to ischemic over a period of 12 to 24 months and an average of 15 months. The natural history of ischemic BROs, they generally have a poor visual outcome. 1/3 of these patients develop posterior segment neovascularizations. NVEs are more common than NVEDs. And as I mentioned, there's not much of data regarding the use of anti-VEGF in ischemic BROs. I'll continue with my next case. I call this double trouble because this patient had two pathologies in the same eye, a 62-year-old lady who had chronic central retinal vein occlusion with a long-standing macular edema in the right eye. And she's had multiple anti-VEGF injections and Ozurdex injection. The vision was very poor, counting finger half a meter, and she had nuclear cataract, axial macular detachment, and she had macular telangiectasia type 2 with a central macular pigment. So this is how our OCT look like. If you look at the OCT, it's extremely gross with extensive intraretinal edema. You can also see this area where you have this pigmentary change happening here, which is classically seen in macular telangiectasia, and she had this traction extending over the macular area. I'm going to show you the images of the left eye, where also she had this classic thinning, foveal thinning, distortion of the ellipsoid zone, some atrophic cyst, and this pigment migration, classically seen in patients with macular telangiectasia. You can also on the infrared, you can see this dipping vessel, which is again a right angle vessel seen in patients with macular telangiectasia. So she presented 6 months later with further reduction of vision, and she also had vitreous hemorrhage at this point of time. So we have a patient who's got ischemic central retinal vein occlusion with macular telangiectasia, with vitreous hemorrhage, with traction there, and gross macular edema. So she underwent a phaco-IOL pars plano vitrectomy, membrane peeling, PRP, and injection of Ozurdex. And this is 2 months post-injection, at which point of time her vision improved to 0.1, not so significant considering she had these ischemic changes. But note, there's extensive improvement in the macular edema with hardly any subretinal fluid. And these changes are secondary to the macular telangiectasia. So in case 2, we had this retinal vein occlusion, macular telangiectasia. The visual acuity is generally compromised by various etiologies. So it's difficult for us to follow any recommendation from clinical trials. So the dilemma here is to consider either separate procedures or combined. So generally, I prefer to do a combined procedure because patients are more amenable to this form of treatment. My last case is a case of, I call it the vexed macula because it has a lot of problems as well, like the previous patient. And this is a patient who got diabetic macular edema. It's a 72-year-old gentleman, had multiple intravitreal injections of anti-VEGF Ozurdex laser done in the past. The left eye was counting finger 3 meters with nuclear cataract, proliferative diabetic retinopathy with a fibrovascular proliferation in the upper temporal quadrant, the scanty PRP marks and an epiretinal membrane over the macular area. So this is how his OCT looks like. You can see this extensive epiretinal membrane, gross traction, the inner retina is torn into folds. You have these intraretinal cysts. You have the thickening in the outer retinal layers. There is some restored presence of the intactness of the outer retinal layer, which probably would indicate a good response if this patient does well. Same like the previous patient, I decided to do a phaco-IOL pars plano vitrectomy with membrane peeling. He also underwent a PRP and an injection Ozurdex. So this is how his scan looked 1 month later. There was still some vitreous haze present. Fortunately, 6 weeks later, this is how his scan looks like. The vision improved to 0.3. Partial, you can see some residual epiretinal membrane on the nasal side of the fovea. And this is 8 weeks following the surgery, vision improved to 0.3. Considering that the way we started, he was doing pretty well with hardly any intraretinal cysts. So to conclude my talk, these are eyes which have proliferative vascular retinopathy. Some of them will have cataract, traction, macular edema. Some might have some exudative component or leakage, primarily to the ischemic retina. So why Ozurdex in these patients? So my rationale here was multifold. Yes, we know there's an exudative component where Ozurdex works very well. It acts on the inflammatory cytokines, which are responsible for the leakage from the perifoveal area. It also is effective for post-cataract surgery associated with macular edema. So we had patients who underwent combined phaco and vitrectomy. We generally do retinal laser photocoagulation in eyes with ischemic retinas, both CRVO and diabetes. And that itself can induce further macular edema. The surgical trauma itself can cause macular edema. And finally, when you have post-vitrectomy or have patients with macular edema, and we have the loss of vitreous depot where anti-VEGF may not work. So Ozurdex is, in my opinion, is the right choice, which tackles all these problems in these patients when they're undergoing a complex surgery, which involves doing a phaco-IOL, a PP vitrectomy, membrane peel, endolaser, and even taking care of the macular edema in these ischemic eyes. So with this, thank you very much for your kind attention, and over to Dr. Amri.
Thank you very much. Excellent presentation as usual, Prasan. All the time you are impressed, everyone listening to you. Thank you very much for this sharing your experience with these unusual cases. And unusual also management. You are thinking about it and
Thank you.
it's worked very nicely. If you can just continue share the screen, because I want to move with you
Sorry.
in case per case, if you allow me.
Sure.
For the first one, I mean, regarding the branch retinal vein occlusion, I have one comment. It's my opinion. I don't know if you agree with me or not. Sometimes we are thinking improvement of the vision from counting finger to 0.5, 0.1 is not important, but I think it's very, very important, appreciated by the patient, especially if the patient having a problem in the other eye. So it's a very nice improvement in this case. So how do you, I mean, you tell the patient maybe they are not appreciating, just I want to know what is the vision in the other eye, if you remember, or why she is not appreciating.
I think the other eye, this lady probably had a cataract with a vision of 0.3, 0.4. She wanted to make sure her left eye was better. She's actually, I forgot to tell you, she's a self-paying patient. So
Okay.
that was also one of the reasons why she didn't want to take anti-VEGF injections. But having said that, all these eyes have poor vision to start with, and they have had, some of them have had multiple treatments. So the hope for these patients at any given point of time is to just have a normal anatomical retina. So when you start treating these patients for many years, or sometimes months to years, they realize they are intelligent enough to recognize how their OCTs look like. So if you show them in their OCT that at least the macular edema is resolved and it continues to remain resolved, though they may not have a significant improvement in vision as compared to the other eye, they are at least happy that now the disease has come under control, and they may not probably need multiple further injections to take care of the problems. So in my opinion, yes, vision improvement may not occur significantly, but at least the patients are happy now that their eye condition has stabilized.
I think,
Mohammed, I just want to comment
yes,
at this point. Yeah,
yes,
I
please.
think it's very difficult when you see these patients at baseline to know how they will, improve. I'm always very hesitant that because it's ischemic, that you assume that patient will do badly. I think it's always worth giving
To
them a
try.
treatment challenge, exactly.
Right.
And what you've shown with your 3 cases, that Ozurdex is a very powerful drying agent. And so sometimes I will inject, show the macular edema is gone, the vision hasn't necessarily improved, the patient hasn't necessarily noticed a big improvement, but they can see the drug has worked. And so it helps them come to terms that you've tried your best, and actually the retinas, the disease has got the better of the eye, the photoreceptors, and there's nothing more you can do. Or on the reverse, because they've got reduced vision in the other eye, that very slight improvement of vision that you've given them, actually it makes a tremendous difference to their quality of life, to their well-being, and you may then continue to treat. So at the end of the day, it's an individual. You have to individualize your treatment and the expectations for the individual patient. For some patients, this improvement is of no relevance, and they will ask you to abandon further treatment, and that's fine. For others, this slight improvement of vision will make a tremendous difference to their quality of life and to their well-being, and therefore you should continue proceeding with treatment.
Thank you, Fahad, for your comment. Actually, I have one comment also, Prasan. The quality of, I mean, those they are having ischemic changes. Sometimes you feel there will be no improvement, but little improvement, it make a difference. This one very important. We are sometimes ignoring, and maybe we know the vision is very important. And sometimes, as I told you, if there is also the vision in the other eye is weak, and there is improvement, it's make the quality of life, as mentioned Fahad, is make difference. Also regarding that you are using a steroid in pseudophakic, you're already making a cataract, and already you are making also a pars plana. One of the indications also to use steroid like Ozurdex after the injection. So it is a great things that you have achieved with all 3 patients. If you want to say something before we move, Dr. Brasan.
No, I'm actually very happy with Ozurdex in using for these eyes. I have actually a few more cases of ischemic RVO and a lot of DME patients where we have used Ozurdex, and it works really well. In fact, in RVO patients, sometimes, as you said, ischemic patients may not improve much, but you will be surprised. Some of them will end up with a vision of 618 or 2060, 2050, or which is quite good considering what they have the starting vision.
I think you have one patient 0.3, which is a very great
Yeah,
achievement.
0.20 partial.
Which is very nice. I mean, improvement, an excellent improvement. Vision and I mean also in clinical or in the surgical way. Thank you very much, Prasan, for your information and your cases you share. Thank you, Fahad, for also being with us in the first sessions. Prasan, if you will be with us also, it will be a great if you have a time, because I think we will need your opinion in certain things that from a vitreoretinal surgeon or posterior segment surgeon in related to the anterior segment speakers. So now it's our time to move to our second sessions, which is about the anterior segment. And today I'm very glad actually, and I'm very happy and proud also to have an eminent speakers with us. And we are going to start to introduce all of them here once, then we can have everyone. We are having in the panelist Dr. Yahya Salahuddin. He's a professor of ophthalmology. I don't know if he is capable to attend or not because he was having a problem with internet. He is a professor of ophthalmology, Cairo University, consultant ophthalmology, cataract and refractive surgeon. He's a chairman of Eye Care Center in Cairo. I have also my dear friend, Dr. Khalid Ayash. He's a consultant ophthalmologist. He's a cataract and cornea and refractive surgeon. He is working in a Khalid Ibrahim Ayash clinic in Jordan. Also, we are going to have our first also our in the panelist, Dr. Osama Al-Jlaidi. He is my dear friend, consultant ophthalmologist, Moorfield. He's a cornea, cataract, and refractive surgeon in Eye Hospital, Moorfield Eye Hospital in Dubai. Our first speaker, it will be actually, it's our pleasure to welcome Professor Mahibal. He's a Professor Mahibal, Chairman and Medical Director Center for Sight and President of All India Ophthalmological Society. Was honored with Padma Shari Award on January 26 in year 2017. He attended professorship in ophthalmology. He's a renowned ophthalmology surgeon who is recognized for his expertise in area of corneal refractive cataract surgeon for both nationally and internationally. There is a lot of things we can talk about Dr. Mahibal, but it maybe is the time not enough to share all his, biography. But we are proud, Dr. Mahibal, to have you with us, and thank you for your accepting our invitations. Also, we are going to have Dr. Elizabeth Yu. He's an MD. She's a partner assistant professor in Virginia Eye. She's a consultant of ophthalmology in Eastern Virginia Medical School. Also, we are also proud to have Dr. Elizabeth with us. We are having also my dear friends, Dr. Safwan Al-Bayati. He is a fellowship, Royal College of Physicians and Surgeons, Glasgow, medical director of New Vision Eye Center, Dubai, phaco-refractive and vitreoretinal surgeon. Also, I am proud today also to have Dr. Ala Dinasuri, a well-known figure in our area and worldwide. He's an MDFR's Chief Medical Officer and Director of the Cornea Refractive Surgery Units of the Maghrabi Hospital Center, Maghrabi Eye Air Dental Hospital, Jeddah. He is a board member of the International Council of Ophthalmology. And finally, and maybe we can say last and not the least, my friends and brothers, Dr. Khalid Muhammad Al-Arfaj. He is an MBBS MD, Associate Professor, Department of Ophthalmology, University of Dammam. He's a cataract and cornea refractive surgeon. I would like to welcome all of you, and we are now going to start our second symposium, and we'll start by Professor Mahibals, and he is going to give an introduction for IOL and premium technology. Dr. Mahibal, the mic with you, please.
Thank you very much, Dr. Mohammad Amri. It's a pleasure being with you and sharing my thoughts. This particular the session is going to be basically about premium IOL, that I am supposed to be laying the foundation on certain aspects on the IOL technology and the premium IOLs that are there. Over the recent years, phacoemulsification has actually brought about a fundamental change in the aim of cataract surgery. From being a restorative surgery, we are moving towards a refractive surgery, which is the outcome that most of us want. That means that we are looking to fulfill the desires of the patient as regards the visual requirements for that particular patient. And to a lot of them, that is a continuous range of vision, giving a person seamless vision from distance till near without any hiccups. The evolution has changed from these thick phakic glasses that was there, going on to the monofocal lenses, and patient nearing to wear glasses if you had a good biometry and you had a good outcome with the monofocal distance vision, patient needing reading glasses. And now the common reframe is freedom from glasses, and if without any dysphotopsias or negative problems you are able to get to this particular goal, this could become a refractive lens exchange, could become a procedure of choice for all those patients who go into the presbyopic ages. Now, all of us know that yes, at times glasses are fashion statement, but typically people are wary of wearing glasses. And whenever you see, there have been several studies, more than 60% of the people, when they go to social functions, they take off their glasses or wear contact lenses. So the aim of the premium intraocular lenses is to go on to areas where you are glasses independent after the cataract surgery, and that is what it is. Now just look at the history that we have, which is close to about 70-80 years. In 1949 to 54, that is the time the original Ridley posterior chamber lens was done, and then you had the interior chamber lenses. From the interior chamber lenses came on the iris supported lenses, then the intermediate anterior chamber lenses were improved, and finally we have the posterior chamber and the modern capsular, that means in the bag placement of posterior chamber lenses which are there. Now Sir Harold Ridley in 1949 in a 49-year-old patient did an ECC with in the bag placement, and what was found was that the power calculation was so off that it was minus 24 diopters with a 6 diopter cylinders, and an IOL exchange had to be done in 1950. From that day, we have moved on significantly in the IOL technology, and now the IOLs are placed in the proper anatomical site, which is from where the original cataractus lens is taken, which is the in the capsular bag, and the loops are now very symmetrical. Also, apart from the big arc of contact that is there, the designs of the IOLs have changed, and we have less of PCO because of the obvious understanding of the tackiness of the material to the posterior capsule as also the square edge. Now, this is something very, very important, that these lenses are giving very low incidence of lens decentration and dislocation. Why I am emphasizing this is, which obviously my subsequent speakers will talk about, would be the importance of the angle alpha and kappa, which is very, very important when you are looking at premium multifocal or trifocal lenses as things stand. Also, you want the tackiness and the lens to stay in position, and there should be no displacement in the toric intraocular lenses, which is again one of the my next speaker is going to talk about. So the lens materials and the loop materials are giving you this particular outcomes that you have, and posterior capsular opacification is less, plus it has become safer even in children. Now, these are various designs that came all, and these are the lenses when I started my ECC. These were the J loop, modified J loop, C loop, etc. And these were the type of lenses that came in. And even you had the Arnold lens coming like this, giving trying to give a very good contact. But typically nowadays you have single piece lenses which are from the PMMA going on to the material from PMMA going on to the hydrophobic material, which is today the preferred material. In between we had the silicon, and these were the haptic materials which have been used over time. But today we have single piece lenses which are obviously hydrophobic or hydrophilic acrylic. These are the most commonly used. Silicon lenses have gone out of vogue. So these are the various materials which are there, and as I said, the acrylics have taken over almost all the lenses, and you have the polymer material which we are using in the ICL or the phakic implant that is there. Now, after having discussed the evolution of the material and the few changes that we have, let us see a couple of two concepts which I think have revolutionized the premium IOL technology, which I don't know why or it took such a long time for them to come, because if you look at the high-end photographic cameras, both these technologies are used in the lenses of the high-end photographic camera. So let us look at the first thing which came, I would say, about a decade or 15 years ago, which is to look at the spherical aberrations in the human eye. So for the spherical aberration, just to go on to the basics and the fundamentals, when you have a young eye, the cornea of a young eye has a positive spherical aberration, as is shown here, which gets compensated by the negative spherical aberration of the lens. So therefore, you have the rays coming from the periphery as also the center coming to a same point of focus. If these were not being compensated, they would be coming to focus at disparate places. And this is the quality of vision. If you have no spherical aberration, you have great. That means that whatever is coming, it is translated onto the retina, and the quality of the vision is very good. Now, when you go on to a mature eye, the cornea remains positive in spherical aberration, but the lens, which was earlier, as I told you, which was minus spherical aberration, goes on again to a plus spherical aberration. So this is a compounding thing that is there, that spherical aberration plus spherical aberration, and maybe that is why when the first intraocular lenses were put, they were also having a positive spherical aberration. So we were compounding the spherical aberration that was there in the eye from the cornea plus the new intraocular lens, and you can see the degradation in the quality of the vision when you are compounding the spherical aberration. Now, this is what the pseudophakic eye with a positive spherical aberration lens, which was the standard of care maybe about 15 years ago. This is where you are having the periphery rays coming to a focus, and this is where you have the central, and therefore you have a blur and the quality of the vision goes down, and this defects the vision. Now, when the concept of aspheric lenses came, so that's what I said, when you look at your high-end cameras, all these lenses that are used in the cameras or even the normal cameras are aspheric lenses. So it took the physicist a long time for us to go on to the aspheric lenses, and when you have the aspheric lenses, a positive spherical aberration of the cornea is thought to be neutralized by the negative spherical aberration of the cornea. Now, this negative spherical aberration neutralization depends from company to company. That means each company thinks that this is the normative data and this should be the amount of negative spherical, positive spherical aberration that needs to be neutralized. And there are some companies which just say zero aspheric lenses. That means that they are not negative and they do not tend to compound whatever is there or to negate whatever is there in the cornea. So these are the new lenses which are there, and when you look at the spherical aberrations which are if you have, they can increase the depth of focus and can reach up to 2 diopters, which is there. Now, as I told you, these lenses typically today have negative asphericity, or the second strategy is minimal spherical aberration, so that even if the lens decenters, if a negative aspheric lens decenters, it can have a deleterious effect on the quality of vision. But if it is zero asphericity, there will be no negative effect, and Bosch and Lomb typically works with zero spherical aberration that is there. But as things stand today, their accommodative lens, crystal lens, is almost, I would say, dead and buried because it didn't work the way it was. So to sum up, the aspheric IOLs, human eye, aspheric optics is what it was when you were young, and that is what was the greatness of the young person's eye. The cornea had positive spherical aberration, young crystalline lens had negative spherical aberration. As you age, the crystalline lens increase the positive spherical aberration, and this is something which caused the problem. And this is where it is. The aspheric lenses today are a standard of care for all toric lenses and for all multifocal and trifocal lenses which are there. So the aspheric lenses, to sum up, gives you better contrast sensitivity, better mesopic vision. Nighttime driving studies have shown that it is much easier and they see at a greater distance, and these are better options for younger patients. The only thing is they need perfect centration, because as I told you, if there is a negative aspheric lens which is getting decentered, a zero aspheric is not going to have that much of harm, but a negative aspheric lens which is decentered will cause decrease in the depth perception, which could be a problem. The only other thing is that the companies have priced it. I don't know still why they have priced it higher than the spherical lenses, but I think the spherical lenses are dead and buried, which is there. Now let us come to the Second thing, which is today, I am not going to talk about the EDOF, Echelet technology or the trifocal technology, but something which is common, which can be used in all platform, is the achromatic technology. Now, asphericity is one technology for all premium lenses that has been used, and the achromatic technology is the other technology which is there. So apart from the spherical abrasion, that means when the periphery of the cornea is coming to a focus at a different point as compared to the central rays, there is also the light, which is the wavelengths of shorter and longer wavelength, that they get split. So when you are looking at a chromatic abrasion, so all corneas have a similar amount of corneal abrasion, and it allows for less chromatic dispersion if you go on to an achromatic lens. So what this happens, technology. So what happens is that if you have the red focusing here, the blue, which is of shorter wavelength, comes to a focus earlier. So therefore, this is a circle of confusion. That means that this particular area, there is going to be some difficulty in the contrast, and this typically plays the aspheric problem, the spherical abrasion and the chromatic abrasion problem get compounded in dim light conditions. So if you correct the chromatic abrasion, then that means the cornea and the lens with an achromatic technology, you will see that the red and the blue come to a focus nearby, and this is something which dramatically improves the quality of vision, and this has been patented by the J&J, and this came in the symphony, which is called as the chrome aligned technology, which results in enhanced image contrast across the range of vision, that is far, intermediate and near. And this is typically in the chrome align, that if you have a cornea which has a chromatic abrasion, which you all know it has, this is a typical IOL which kind of compounds like in the spherical. But if you have a diffractive IOL with chrome aligned technology, you can see that the blue and the red, the difference between the two focuses is much less. The third thing which people have been talking about is the UV blocker, the yellow lens, or now what is considered is that if you don't want to have a problem with the circadian vision, and also the LED light sources, which are most prevalent nowadays, they produce the maximum scatter due to emission of shorter violet wavelengths. And the violet light filtration blocks the shortest wavelength, that is the violet wavelength, which produce the highest levels of scatter. So the scatter by having these violet wavelengths blocked is getting down, and Alcon has this technology which is separate, which blocks the entire ultraviolet or the blue spectrum. But this is typically looking at the this is typically blocking the violet, which produces the highest amount of scatter. And there are various studies to show that the ease of driving goes up when you are having this violet blocking. And you can see that the even with the iPhone, it is photopic, there is a 13% decrease. These are bench data. And xenon headlight, there is a 29% decrease in the halo intensity, which is there. So these are a couple of things I would say. And then what has become standard of care from the non-foldable is the foldable IOL implantation. And you are using the folders, injector systems, which are very good. All that I'll wish to say is that we need to be very careful. I will just to show a slightly more dramatic view. This is a 3-piece lens, which a lot of people don't use. If you do not fold the lens properly, you can open it with a jerk, or you can open it upside down. That is something which is very, very important, that you need to open it in the proper way, and the lens can flip over, as you can see in this particular video, that see the lens is flipping over because it has not been opened in the proper way. Another thing is that there was a lot of emphasis on making the incision small. A clear-cut incision which is there in a foldable lens is much better. Here you are using the mouth of the incision as with the injector cartridge to put in. But what is happening is, you can see this is billowing and the lens is not going in, and the lens gets stuck. You can see that the lens is getting stuck in the incision. So please, all these are foldable, delicate lenses, and you don't wish to kind of spoil the optic of the lenses. And you need to have the proper injector system to be able to inject the lens properly and not get stuck up like this, where you are having the lens and then you will have to kind of pull it out and do maneuvers to do that. So friends, just to put basic concepts for the intraocular lenses technology that has gone up. It has gone up from the non-foldable lenses to the foldable lenses, acrylic being the gold standard today. It has gone from the PMMA to the acrylic material. As I told you, it has gone on to single piece lenses. The lenses are much more stable, and the lenses today have in them square edges. They have good tackability of the haptic and the optic to reduce the PCO and to provide you good centration. And for all premium lenses today, we have the aspherical lenses consideration that is there, and the achromatic lenses which is there. So the journey of IOLs is long and upwards, and now you have photo light ablatable lenses which we can fix or refix their power after the IOL has been implanted in the eye. So we wish to have the lens which does not cause any dysphotopsia, which my the speakers to follow will talk about, which gives you good continuous range of vision. And I think we are nearing that reality today with these kind of intraocular lenses which is there. Thank you very much for your kind attention.
Thank you very much. Thanks a lot, Dr. Maibal, for an excellent presentation. And you cover most of the points regarding the monofocal lenses. I think if there is any question from dear here, Dr. Khalid, Ayash, Dr. Safwan, or Dr. Osama.
I have one comment, Dr. Mohammed, if you
Yes,
don't.
please. Yes, please.
Professor Mahipal, I need to thank you that you're shortening my journey in discussing the aspect of spherical abrasion, positive and negative. And I'd like to thank you here again because you explain it in a proper way. So it will shortening my journey. Great, thanks for you.
Dr. Osama, if you have any questions or comment actually to Dr. Maibal.
No, that's very, very good talk, really covered from basic to advanced, and I think it's very good, well done. I don't have a specific question at this stage, but I'm sure there's a question at the end of that.
Dr. Yahya and Dr. Khalid Ayash.
Thank you very much, Dr. Muhammad. No, it was very good, excellent. I don't have any additions for now.
Okay, if we want to say, there is a question in my mind. I don't know if anyone can answer, or it's a comment, and I want your, what is now the location of monofocal from our work? So where we are standing from the monofocal lenses.
Okay. As regards monofocal lenses, I think as a disclaimer, I am a consultant for J&J and on the Global Advisory Board, but I think the introduction of eye-hands lens and now in the US of the eye-hands toric lens, which is a monofocal plus lens, at no significant increase in the cost, because in India and other places, the cost difference is about 20 to 30% of the monofocal, and we don't talk to our patients that we are giving you anything else, and it does not have any dysphotopic phenomena, but it has reduced the requirement of reading glasses from plus 2.75 to 1.5 or 1.75. So without an additional cost, the patients are much happier, and if you do a monovision for them, they are in significant work. They are independent of glasses. So at least in my practice or in our practice at Center for Sight, the monofocals are very significantly out. And we have replacement with what we call as monofocal plus, which is the eye-hands lens. Toric lenses, we are more and more aggressive in doing toric lenses for any toricity today for more than a diopter. For diopter, less than a diopter, between 0.5 to 1 diopter, we are looking at the LRI from a femtolaser. Personally, I do 70% of my cataracts as femtolaser procedures. So we try to correct that astigmatism. And the second thing in the journey, according to me, is that the bifocal lenses are on their way out. The trifocal lenses which have come and the continuous range of vision lenses that have come from various companies, not just one company, various companies have reduced significantly the dysphotopic phenomena, and these asphericity, achromaticity, and the smooth phase technology, etc., and the combination of an EDOF with the trifocal technology has really changed the scenario, I would say, over the last 3 to 4 years. That is, so monofocals will slowly be on their way out, and I think more and more companies, there is some European company also that is coming out with an equivalent of an eye-hands. And I think they are going to replace monofocals in due course of time because the price difference is very little.
Thank you very much, Dr. Mahibal, for this excellent presentation and also explanation. There is a question from Dr. Brasan. He is with us now in the here panelist. He is asking about, or he is asking Dr. Mahibal, any experience with mini well lens? They are supposed to be ring lens lenses. I don't have. Okay.
Two lenses, Dr. Prasan. There are two lenses, Minivel and Lucidis. These are two lenses which are actually a kind of an EDOF lens. Like the iHands is a ringless lens. Similarly, the Minivel and the Lucidis are having a higher amount of the profile, which gives them a much better near vision or an intermediate
We give
vision.
a good discussion in EDOF that related to the manual and Lucidus. So we will in detail explain all the details related to these two lenses. So let Prashant be patient, and it's coming.
Okay, we can move actually, Dr. Ala, if you have any comment before we move to the next speaker.
No, I think that was excellent, and I do agree that the monofocal lenses have a little place today, and this place is getting less and less over the years, because better aspheric lenses are definitely better lenses. So I totally agree with Dr. Mahipal.
I think Dr. Elizabeth is not yet joined with us. So if you allow me now, we can take Dr. Ala talk first. And she is saying she can be able to join later on.
Can I have 1 minute and one comment?
Yeah, please.
When we will have an EDOF simple, pure with the toricity, and that it's coming, then there will be no mean for any other monofocal to be present. So the toricity with EDOF, it will cancel the monofocal for time being. For time being, unfortunately, we don't have the toricity for those. It's coming. So I will keep continued when I will discuss my presentation.
Thank you, Dr. Safwan. And now is the talk with Dr. Ala, and Dr. Ala Dinasuri. He will give a talk about the multifocal IOL. Dr. Ala, the mic with you, please. You are mute, Dr. Ala. If you unmute yourself, please.
Okay. Thank you, Dr. Muhammad, for the invitation. I really appreciate it. It's always my pleasure to share podium with you and these distinguished speakers.
Our pleasure, Dr. Ala. It's our really pleasure to be with us. Thank you very much.
Thank you. Thank you so much. In the next 15 minutes, I'm going to share with you my experience or our experience at the Maghrabi Hospital, the trifocal lenses. We started using these lenses some 5 years ago. I'm consulting to Physiol, who is the manufacturer of the first ever trifocal lenses. And to start with, let's prepare the ground by saying that multifocality is an optical compromise. So when you're saying multifocality, there is a give and take. You're giving something in order to take another thing. So it's the amount of giving versus the amount of taking that dictate the success or the satisfaction of these patients. So we need to understand and agree that there is a kind of compromise here. If you go back couple of decades before, when we used the bifocal lenses, and we called them multifocal at that time. So that's why I always insist on calling the trifocal lenses, not to confuse with the bifocal lenses that we were calling multifocals before. Bifocal in my practice were never the standard of care, and I think most of you will agree with me upon this. And the main reason was the poor intermediate vision. These lenses were giving good far vision, good near vision, but the intermediate vision was very poor. And this ended in a very long chair time, high rate of unsatisfied patients, high rate of IOL, of bifocal IOL exchange with monofocal lenses, and so on. So that's why the bifocals were never the standard of care. Remember that intermediate vision today is of extreme importance. I would say it's as important as near vision and far vision today with the era of the iPad and laptops, and we need the intermediate vision as much as we need the near and the far vision. With the introduction of the trifocal lenses for the first time after the work of Damien Gatinel and Parnouille from Physiol, they combined two diffractive lenses, two bifocal lenses, with many improvements over the previous bifocal designs, including the apodization, the convolution, which is the smoothening. The lens had a toric design. It's aspheric, as we learned from the previous talk that aspheric lenses are the way to go. They start with the hydrophilic lens that I'm still using till now, and hydrophobic is also available in many countries. When we started using these lenses many years back, I was very skeptical, coming from the background of the bifocal lenses with less than optimal patient satisfaction. So we designed a clinical trial to evaluate these lenses prospectively. So we included 36 patients, 72 eyes, who had bilateral phacoemulsification, whether for a cataract, which is usually an early cataract, or refractive lens exchange. And most important thing here are the exclusion criteria. So we excluded all patients who might have any reason for visual quality compromise. I'm not only referring to macular degenerations or glaucoma or big things like this, but for those patients who have subtle changes like Fuchs endothelial dystrophy with corneal guttae, inducing some corneal scatter, patients with corneal high order aberrations, whether from a previous laser surgery or from some corneal scarring. These patients were excluded. We excluded patients with large angle kappa or large angle alpha, because as we know, centration for these lenses are very important. And you typically need these lenses to center both on the center of the pupil and on the visual axis, which is of course impossible. So the best position of these lenses is somewhere between the visual axis and the center of the pupil. So patients with large angle kappa or large angle alpha might not be suitable for multifocal, trifocal lenses, though this is debatable and we can open the discussion here. Also, patients with dry eye were excluded from this study because this compromises the quality of vision. And we used toric lenses for anyone who has a corneal astigmatism of 1 diopter or more. So more than 50% of our patients had trifocal toric lenses. The POD-F and POD-FT, these are hydrophilic lenses, and now the hydrophobic is available. They have a double C loop, and I like this double C loop as opposed to a single C loop, because the 4 point of centration makes the lens more well-centered, more stable, and the rotation of the lens in the bag, especially toric lenses, is easier and can be done on both directions, clockwise and anti-clockwise. So usually at the end of the surgery, when you remove the viscoelastic from behind the lens, which is important, especially in toric lenses, then you don't have to rotate. If you have to rotate the lens to any direction, you can do it both ways, which is an advantage of the double C loop as opposed to the single C loop. Another advantage of the double C loop is that it does not give you this posterior capsule striae or wrinkles that we see with the 2-point fixation lenses, because here we have 4 points of fixation. Now let's look at the results of our study. We actually measured everything that we can measure. We measured the far, intermediate, and near visual acuity without correction and with distance corrected. We measured the pseudo accommodation, the defocus curve. We measured the scatter with the OSI, the objective scatter index. We measured the high order aberrations. We measured the MTF, modulation transfer function, the contrast sensitivity with and without glare. And we had the patient questionnaire at 6 months. So basically, we measured objectively everything that can be measured for assessment of the quality of vision. And this result just came into the Journal of Refractive Surgery last month in the June edition of the JRS. The clinical outcomes after phacoemulsification with implantation of the trifocal and the toric trifocal lenses. At 6 months, you can see here the refractive outcome were excellent, 89% plus and minus half, and all eyes except one were between plus and minus 1 of emetropia, of the target refraction. At 6 months, the uncorrected distant visual acuity monoocularly was 30 in 100% of the patients. The same when we measured monoocularly at 6 months. So all the patients could see 20/30 or better, 94% could see 20/25 or better. We measure the distant corrected near visual acuity. And here I'm just drawing your attention that in order to properly assess the multifocality, you need to measure the near vision with the distant correction, because if the patient has a minus half or minus 0.75, even with a monofocal lens, you'll be able to read properly. So you need to have a measurement of the near and intermediate vision with the distant correction in place. We use the clinical trial suite, which is a sophisticated software that eliminates the technician bias. It's randomized. It can also measure far, intermediate, and near vision, and it generates automated defocus curves. So at 1 month, monoocularly, 86% could see 20/30 or better at 40 centimeters. And at 6 months, 94% could see 20/30 or better at 40 centimeters. So the near vision for this patient was really good. Intermediate vision at 80 centimeters at 1 month, 86% of the patients could see 20/30 or better monoocularly. At 6 months, 91% of the patients could see 20/30 or better binocularly at 6 months. Again, with the distant corrected vision in place. Now, the defocus curve, it's important to measure the defocus curve for all these lenses if you're talking about multifocality. And just to give you an idea for those who are not aware of the defocus curve, this is the defocus curve of a normal patient, a phakic, non-presbyopic patients, young patients with perfect vision. So the far vision would be in the range of 20/15, intermediate vision, the same thing, near vision, same thing, and then it starts to decrease by the end of the curve. If you do the defocus curve, if you plot the defocus curve of a patient with a monofocal lens, it will have an excellent far vision, and then the intermediate vision drops and the near vision drops even more. With bifocal lenses, the old bifocal lenses, they have an excellent far vision, a very good near vision, and very poor intermediate vision. And this trough was the reason these lenses were not really satisfactory. Now, the trifocal lenses that we are talking about today, if you plot the defocus curve, which is shown in red here, have an excellent far vision, an excellent near vision, and very satisfactory intermediate vision. It's less than 20/20, but 20/25 for the intermediate vision of 20/30 is very acceptable. So this is the big advantage of the trifocal compared to the monofocal or bifocal lenses. We also measure the contrast sensitivity with and without glare. The red curve shows the contrast sensitivity without glare, and the gray curve shows the contrast sensitivity with glare. At the low frequencies, there is no decrease of contrast sensitivity compared to the normal curve, which is shown in dashed line. But in higher frequencies, there is little bit of loss of contrast sensitivity. And this is the compromise. This is what we give in order to take a good intermediate and near vision. Now, the last thing we measured was the scatter. And remember that these multifocal lenses induce scatter. If these lenses are properly centered, the main aberrations that will induce is scatter. And scatter is not measured by aberrometers. The only way to measure scatter objectively today is the HD analyzer. and it gives you a number, the objective scatter index. Example, this patient has a cataract with an objective scatter index of 6.6, very poor quality of vision. After 6 months after surgery, the objective scatter index improved to 1.2. So this is the scatter index after the surgery. So this patient gained a lot in terms of quality of vision. It was 6.6, after surgery, it's 1.2. Now, there is a difference between patients with cataract, shown in blue here, and patients with clear lens, the refractive lens exchange, shown in orange color here. When you start with the cataract, you have a high scatter index. You have a high scatter. Then after the surgery, phacoemulsification, you remove the lens, you inserted a trifocal lens, the scatter index decreases. So the patient feels much better quality of vision than before. On the other side, if you have a refractive lens exchange, the optical quality of this eye is excellent, with an average of 0.9. So if you remove the clear lens and insert a trifocal lens, the quality of the vision decreases, because these trifocal lenses have a less quality of vision compared to the natural crystalline lens. So the objective scatter index increased in this eye from 0.9 to 1.7. Still better than the cataract group, but it's worse than where we started. That's why we have to be very careful when we select your patient. The happiest patient, the patients who are over the moon, are those patients who have cataract, so they have a poor quality of vision and poor visual acuity, and presbyope. So when you do phacoemulsification and trifocal lenses on these patients, they gain everything. They gain visual acuity, they gain quality of vision, they get rid of their spectacles, they restore their near vision, and they restore their intermediate vision. So these patients are no less than extremely satisfied. They are over the moon. Those patients with clear lens, if they are presbyope and have hyperopia or high myopia, they will be very happy because they get rid of their spectacles, they have a better near vision because they are presbyope, they have a better intermediate vision, and they maintain the quality of vision. So they actually did not lose much after this surgery because they had a high refractive error. Those patients that we need to be very careful with are those patients with high refractive error, but clear lens, no cataract, and no presbyopia. So unless these patients are very motivated, you better be very careful with them, because they have an excellent quality of vision, OSI 0.6 in this case, high hypermetropia with +6, and after the surgery, the quality of vision will decrease from 0.6 to 1.2. So this patient is losing some quality of vision, but he is gaining, he's getting rid of his glasses, he's maintaining his near vision and maintaining his intermediate vision. So what is he paying is some quality of vision that he is losing. So you have to be very careful with this kind of patients. Now, when we asked our patient at 6 months about their satisfaction, we had a subjective questionnaire. So all the patients were either satisfied or very satisfied. Only 12% of the patients spontaneously reported halos at night, but all the other patients, 87% of the patients, when they were asked about the photic phenomena, they said, yes, at night we can see some halos around the light, but it's not disturbing. If this is the price you're going to pay to be able to see far and near vision, that's more than welcome. And all the patients said they would have the same lens again if they were given the choice. So in conclusion, we strongly believe that trifocal lenses, with the design that we used in this study, gave satisfactory far, intermediate, and near vision. Toric trifocals are very important and very effective in compensating the corneal astigmatism. Emmetropia should be the goal in all these patients. Any impact on the visual acuity, there is some impact on the visual acuity, but it's very acceptable. And if this is the price the patient will pay to be able to get rid of intermediate and near glasses, they are happy to go this way. We have to not to overpromise the patients and explain to them that we are not restoring accommodation, but you are giving them an efficient way to compensate for the loss of accommodation. So the pearl for success, after our experience with trifocal, is that you have to measure the actual quality of vision in order to be able to exclude patients who will not be satisfied. Target emmetropia in all the patients. Don't hesitate in using toric lenses, even in a low amount of astigmatism. Don't hesitate to realign the lens if the lens is not properly aligned on day 1 or week 1. Exclude any patients with possible poor outcomes, especially those with high order aberrations, corneal high order aberrations. Be careful with the patients for refractive lens exchange and never ever overpromise. And I thank you for your attention.
Thank you very much, Dr. Ala, for an excellent presentation. Is there a question? There will be a lot of questions, actually. Can we have a question from Dr. Khalid?
I have a question.
Yeah, Dr. Yahya, please go ahead.
Thank you, Dr. Ala, for excellent lecture as always. I would like to know which formula do you use for biometry, and you were just saying you aim for emmetropia. So binoculary, you always aim for emmetropia. And what about post-refractive surgery cases, laser refractive surgery cases? Thank you.
Yeah, that's very good questions. And I know that you know all these answers, but just want to open it for discussion. So I use the Barrett formula and the toric for Barrett toric calculator for the toric lenses and the Barrett universal. For the patients with yes, I'm aiming at emmetropia for in all the cases, and I would go to a little plus. You know, these lenses come in 0.5 steps. So sometimes we're given the choice plus 0.12 or minus 0.12. In these cases, I'll go to plus 0.12 in these lenses as opposed to the monofocal lenses. Toric lenses, yes, for all patients who have even little amount of astigmatism, especially the against the rule astigmatism. If the patient have 0.75 diopter of against the rule astigmatism, I would correct it. But if 0.7 diopter of with the rule astigmatism, I might go with spherical lenses. So I'm a little bit more aggressive in correction of the against the rule astigmatism. And I always look at the posterior corneal astigmatism because, as you know, in many cases, the posterior corneal astigmatism compensates the anterior corneal astigmatism in most of the cases, but in some cases it just adds to it. So that's my approach.
Thank you, Dr. Ala. Dr. Khalid, if you have any question or comment.
Thank you, Dr. Ala. Very nice and very comprehensive presentation. My concern with the visual lenses is the rate of PCO. Can you mention this? Because it's a very nice, good lenses in near and in distance and intermediate, but sometimes every now and then we face patients that come with a PCO.
Yeah, the rate of YAG capsulotomy in patients with premium lenses is usually higher than patients with monofocal lenses, regardless the type of the lens that you are using, because these patients who opt using premium lenses are more demanding. And usually in the first few months before the PCO develops, they are happier. Then once they have the slightest PCO, they start to complain. So in my hands, more patients with premium lenses, whether toric or EDOF lenses or trifocal, Physiol or other platforms, they have higher rate of PCO, not because these lenses induce more PCO, but because these patients are more demanding. And I do not hesitate in doing any YAG capsulotomy for these patients after 3 months or more after the surgery. I usually prefer to wait for 6 months, but I do not hesitate to doing this. I do not think that Physiol has a higher PCO rate than other multifocal lenses, but I think that the type of patients are asking for YAG capsulotomy more than the others.
Thank you, Dr. Ala. Dr. Usama, if you have any comment.
Thank you, Dr. Ala. That's very good, comprehensive cover. As you say early, the trifocal help us a lot, really, because the monofocal before is always, I remember these sessions to mix and match and all these lenses, it was a bit tricky what to choose. And so life much easier with trifocal, just aim it for emmetropia. That's good. One thing is about the pupil size, preoperative. What's your cutoff and how relevant is it?
Well, yeah, thank you, Osama. That's a good point. And since you mentioned the mix and match, I would not mix and match anymore. I would not use different platforms, different eyes. I have some patients with trifocals, different brands in both eyes with excellent surgical outcomes and refractive outcomes. But patients are always complaining when they have two different lenses. I'm not saying one is better than the other, but it's always better to put the same brand in both eyes. So mix and match with different lenses is not the way to go. Regarding what was your other point?
Pupil, the
Yeah, the
pupils.
pupil diameter. I don't go with trifocal with very small pupils. Someone who has extremely small pupil, like 2 millimeters or less, then I wouldn't go for trifocal. If the pupil is large, it's 3 millimeter or 2.5 or larger, it's okay. I don't mind. With the apodization, which means better near vision when the pupil is small and better far vision when the pupil is large. Because as you know, when we do the near reflex, when you're reading, the pupil gets smaller. So more energy goes to the reading part. And if you're looking far away, the pupil gets slightly larger, so and more energy go to the far vision. So I like the concept of apodization. So the pupil size is not a big factor in my practice, in my patient selection, unless the pupil is really small, like 2 millimeter or less.
Is there any comment, Dr. Safwan or Dr. Khalid Al-Arfaj?
Well, I think that,
Dr. Mahibal, also, if you want to ask any question, Dr. Safwan.
Dr. Ala, a very good discussion, a very good presentation as usual. And a diffractive mode Physio is one of the best lens that I used in my life since 2013, 14 and on. And I'm presenting Physio here in UAE. The hydrophilic is only the drop up of this lens. Dr. Khalid mentioned few things, and your answer is absolutely right, that we are doing a YAG for all. I think that we need to go through the IDOF, because IDOF have a lot of discussion. So if you allow me, Mohammed, to go in and save the time, and we'll discuss all the issues related.
Yeah, but one last comment about the hydrophobic and hydrophilic. Hydrophobic lenses are more demanded by the surgeons, but hydrophilic lenses give better quality of vision.
Exactly. I do agree fully.
And so it's pressure by the surgeon. So if I'm using hydrophilic lenses, I'm very happy with the outcome.
Exactly.
But I understand the pressure on the company to induce and introduce the hydrophobic. So the hydrophobic
stopping it because a complication of hydrophobic is in front of us. So
Dr.
Mahib is one of the important issues. Okay, I'm ready, Dr. Mohammed.
Well, just 1 second. Dr. Mahibal, if you have any comments about or questions. Dr. Mahibal, Dr. Khalid, you are you are mute before. Sorry,
Okay. I enjoyed your talk, Dr. Ala.
Dr. Mahibal is giving his Dr. Khalid 1 second. Dr. Mahibal, go ahead.
Yeah, so I think as was pointed out right in the beginning by Dr. Ala, that the bifocal lenses had really a problem, and now the trifocal lenses are, we have become much more aggressive because I have done more than I think about 1,200 of these trifocal lenses, and I had not had a chance to explant even one of them. Though there is one patient who is relatively dissatisfied with the whole thing, and I'm planning to do a refractive correction for a touch-up for a residual refractive error. But I think these lenses have evolved over time, whether it's the Physiol, whether it's the Zeiss. These are the two that I use, but now I am finding the quality of vision to be as good with the Synergy lens. The only problem with the Synergy is that it does not have a toric version just now. A toric version is mandated in any lens, because a degradation in the or if there is a residual refractive error, that causes a degradation in the quality of the vision. And as was rightly pointed out by both Dr. Safwan and Dr. Ala, that YAG capsulotomy degrades the vision, because as it is, the light is split up into 50, 30, 20 or whatever ratio it is. And any wrinkling even on the posterior capsule degrades the quality of the vision. So you have to be much more aggressive in doing a YAG capsulotomy. But I think the era of the trifocal lenses is definitely in, and bifocals are dead and buried, as would monofocals be. That's what my thing. And a toric overhead is mandatory for any trifocal to take care of the astigmatism, and against the rule astigmatism needs to be taken care of. I think if there is a talk on toric, the TK is something very important. Even if you don't have a IOL Master 700 to get the TK, you should have the simulated or the extrapolated TK looking into the posterior keratometry, posterior corneal curvature into account for carrying the calculating the
Thank
toric.
you very much, Dr. Mahbal. Last comment by Dr. Khalid, please. Dr. Khalid, if you have something to say about
your talk, Dr. Ala. You sum up everything almost about the new trifocals, and we all agree that it has a very important market. And I will just ask about very important question about the YAG, since you mentioned, and the YAG is really high. We need the YAG sometime in 50 to 60% of the both trifocal lenses, many of these types. But my question is, do you notice any change of refraction after doing the YAG? After if you do it early, that's why I'm suggesting to
the lecture,
delay a little bit. Do you see any delay? I mean, change of refraction sometime? If you I mean, just 0.5 or 0.75, maybe the lens position might change a little bit after the YAG.
Well, I'm not sure I'm muted now. Not significant changes. I'm not doing the YAG early. I'm doing the YAG at least 3 months, and I always prefer to do it at 6 months or more because of the possibility of cystoid macular edema and inflammation and so on. So I always try to wait at least 6 months after the surgery, and also to make sure that the patient is happy with the vision, because this comes from the bifocal experience. You don't want to do YAG unless you're sure that you're not going to exchange this lens. With the bifocal, that was the concept, and but now with the trifocal, and as Dr. Mahipal mentioned, I also did not have to exchange any of these lenses. So the answer to your question, the short answer is I didn't see significant change in refractive error after the YAG when I do it 6 months or later.
Thank you very much for all. So we can move.
I will just say one thing for this topic. Can I?
Yes, please, very fast. Dr. Safwan, he
Very
will kill
fast.
me.
Dr. I usually do, particularly for young patients, because of this, I do primary posterior capsulorhexis. It's for debate, but just I wanted to say what I do.
Okay, maybe we can comment about this one later on after
later,
Dr. Safwan he finishes.
I will open
talking.
discussion for that, and Jay, thanks for all.
Now we can have Dr. Safwan, and he is going to talk about EDOF IOL. Please, Dr. Safwan.
Good evening, everybody, and I would like to thank Dr. Muhammad definitely to give me this opportunity, and to thank all the speakers before me that opened the road widely, especially Professor Mahipal and Dr. Ala. And I didn't say hello to Dr. Ala, and that he's very close to me and to my heart. So we will start with EDOF, as Professor Mahipal mentioned few things, synergic and lucidus, and see, we have a lot of terminology, and so we are talking about the confusion of the terminology, unfortunately, and we will clarify it. It's clear. EDOF, as a pure EDOF, is the I don't have any financial disclosure here for any product will be presented, except that I'm just presenting for physio here in presentations, but no any financial disclosure. EDOF, it's an extended range of vision, extended depth of focus, extended depth of field. So we need to find out what's the difference between all. So it's a new technology in the, if you don't just let me to modify the big font in a way that I can. So it's a new technology in the treatment of presbyopic correcting lenses. The basic optics principles to create a single elongated foci point to enhance the depth of focus on the contrary to monofocal IOL, in which light is focused on one single point, or multifocal IOL that having 2 or 3 decrease point, as Professor Mahipal and Professor Ala said. This is elongated focus, or this elongated focus is introduced to eliminate the overlapping of near and far image caused by traditional multifocal IOL. Thus eliminate the photopsia, halos, glare. Ideally, these IOL should enhance intermediate and near visual performance while minimally affecting distance vision. EDOF IOL provide a continuous range of focus without clearly asymmetric IOL power distortion. Avoid the presence of secondary out of focus image. So here, by introducing EDOF, our aim is to eliminate the trade-off that Dr. Ala talked about it. The trade-off is that to compensate means that I will accept halos to compensate gaining near vision. So the goal of the EDOF is to reduce that trade-off. Increased depth of field, that I will show it in a clear way, might have a trade-off, which is a decreased visual quality, particularly if the aberration magnitude that is the concept of this technology is too large. It leads to reduction in distance image quality. That's why pure EDOF, when we are talking about pure EDOF, it's not more than 1.5 add, which means minus 1.5. And these are the things that we will discuss it. Overlapping of percepted image with dysphotopsia phenomena, that it happens if we will increase the spherical aberration over the 1.5. Several optic bench reports have shown that EDOF lenses provide better optical quality than multifocal and monofocal lens. Nevertheless, in practice, EDOF lenses provide excellent intermediate vision, but inadequate quality of near vision and distance. So still we have a problem with the near vision. As a history, in June 2014, first EDOF IOL Symphony from Johnson & Johnson Vision was produced, and as a trading was introduced into the Europe market, have received the European Economic Area Certification mark. Consequently, the Symphony was also the first EDOF labeled IOL approved in the United States 16. Since then, several EDOF labeled IOL have been released in the market. Those IOL have been presented now in this label. Now, this label showed the summarized, at least published study there on their product. Now, pure EDOF that depend on a concept of a spherical aberration based, the negative spherical aberration that we will discuss it here. We have the thickness eye-hands that we know it, and vivity that's not present in this label because it's newly launched, and isopure from the physio, also not presented, and this is a published study. Unfortunately, they didn't test it. Those they are using only a spherical aberration base. They add only plus 1.5. The EDOF that utilize pinhole like IC8 and extra focus pinhole implant, it's not widely used. I don't have any experience with it. The hybrid multifocal, we have several forms of it. The hybrid diffractive, the diffractive one that Dr. Ala talk about it, we have an add of EDOF on it with a modification in the diffractive spikes of it, that thickness Symphony. And we have hybrid multifocal refractive EDOF, and that was Dr. Rao asking about it. That's Lucidus, one of it, and we will explain in details what about it. The other one is the hybrid multifocal refractive diffractive EDOF. In the multifocality, we have those three: diffractive and refractive diffractive way. Now we are adding the EDOF technology to each. The aim is to reduce the halos and to increase the energy to the near and intermediate and to the far, and reduce the photopsia that present. Now, so pure spherical abrasion light rays that, as Dr. Professor Mahipal presented in a very clear way, that if you will go to the left side, this is the ideal, where the light beam hitting the lens and coming into one point. It's not present in the normal human eye, unless the lens, normal human lens there, and it can neutralize the effect of the cornea. Cornea having positive 0.3 around spherical abrasion. So if we are putting a lens in spheric form 0, then we will have the second picture. This distorted images resulted from that beaming coming from the farthest point from the center will be bent more than the beam coming from the center. But if we will neutralize it by an other lens having a negative spherical abrasion, that degree of the negative spherical abrasion, we can adjust it either to create a 0 or to elongate the depth of focus. Minus 0.25, then we will create a 0 almost in around 85%. But if we will use it in more, like minus 1.5, then we will create something called extended depth of focus. So as written, positive spherical abrasion means the peripheral ray are bent too much. Negative spherical abrasion means peripheral ray are not bent enough. So if we can neutralize it, and this is the technology that they add some negative spherical abrasion on the surface of the lens, usually the anterior surface, to create such a neutralization, or to create a negative side in a way that they can extend the depth of focus. For any given eye, as I said, and this is the same issues that I explained it, and that picture down, it shows that the effect of the negative spherical abrasion add to the lens, and how it extend by neutralizing the highest bend from the periphery to make it bend in a certain point that we targeting it. But unfortunately, we cannot go through above 1.5, because if we will go above 1.5, we will have a bad quality vision for the distance. That's why the limitation of the spherical abrasion here is 1.5. Now, that's the lens presented in this way, and this is one of the example of the lens that shows the effect of the adding spherical abrasion on, and we have now at least few lenses, few examples, at least, and for example, in the area that where I'm practicing in, we have the Technus eye hands, where the company, unfortunately, they are not adding it under the EDOF, but it has an add of EDOF, but it's not more than 1. And I have not a good experience with it. It didn't add anything for the patient. Most of my patients, they are even not able to read the computer in a way, in a good way. The other example is the Physio Isopure, which add 1.5, and Vivity now from Alcon, which add also 1.5, and have the same technology, is the spherical abrasion on the anterior. Now I will show you here. This is the Isopure on the left side, where there is no marking on the lens, on the anterior surface of the lens, shows the spherical abrasion. On the right side is the Vivity alconvivity, where there is a marking shows by the arrows, and it shows how how they implant that spherical abrasion on it. So in that, we can see above it how that lens can bend the light in a way that it will extend the depth of focus and reduce the gap between the distance and the intermediate. So those lenses having a very good intermediate vision, but unfortunately they have poor vision. Most of them, 40%, according to the studies that they publish it, they have a good standard near vision, according to 40 to 50. Now, down left, there's a comparison between a monovision on 0 and a myopic person that having minus 1.5, and a mixed astigmatism which has vertical but they have some near vision, but it's blurred, and the EDOF on intermediate vision on minus, that it gives a quality of vision equal to someone that having minus 1.5 myopia. Now, that's the same diagram that I was explaining. Now, the EDOF with utilizing pinhole, as I explained, that it utilized around 1.36 aperture surrounded by 3.23 millimeter mask. It's non-diffractive, but masking the whole light that can opaque mask within 1.36 millimeter aperture, which block defocused paracentral light rays and allow entry of paraxial light rays, giving an EDOF effect. Multifocality, when we're talking about it, the 3 types: the diffractive that Dr. Ala talked about, and refractive IOLs, and refractive diffractive hybrid. Those are the multifocality. If we are adding EDOF to it, then we have a hybrid diffractive, hybrid refractive, and hybrid refractive diffractive. So diffractive, as Dr. Ala said, that there is a light diffracting at an interface grid to produce a different foci. In refractive power change from center to periphery of lens and produce many foci. Diffractive refractive, central progressive refractive zone within 1.5 millimeter, surrounded by diffractive zone 1.5 millimeter to 3.8 millimeter of a diameter that allow far and near vision in full range of pupil size. The progressive power refractive zone allows far and intermediate vision, and apodized diffractive design minimize light loss outside and reduce halos in the far focus. Additionally, aspheric lens peripherally improve image contrast in large pupil for different corneal asphericity. Till now, we are talking about multifocality. So and that's the concept of each one, with a chromatic abrasion correction, that in thickness only. So on the left up is the spherical multifocality. On the right up is the diffractive multifocality. And on the left down, there is 2 kind of refractive. Here it's on the right down, there is a bifocal, which Dr. Mahipal said that it's out of order, and I don't have any experience with it. The down left is the refractive diffractive one, and I explain it, all the details of it, and this is the diagram of the lens. Now, hybrid is the best label that we can prescribe the IOL combine multifocality with the low addition power and as an EDOF technology adding. Why we are adding EDOF here for those technology? What's the benefit of adding it? Reducing the add for near and adding to the half, and adding the ability of EDOF technology as 1.5, for example, diopter and reducing from the spherical part or diffractive part 1.5, this will enhance the distance vision and reduce the photopsia night. The first one, the hybrid multifocal diffractive. This is a new model of diffractive multifocal IOL, having reached high standard of clinical performance target that decrease in halos and the glare by decreasing the near optical power, substituting it by EDOF effect. Techness Symphony is an example of it, and that's the diagram for it. The posterior part of this lens having a diffractive, anterior part having the asphericity or the negative wavefront, negative spherical abrasion. Now, and that's the issues. How we compare Techness Symphony to Techness bifocal, where it has 22 rings, comparing to Fine Vision trifocal having 23 rings, in Symphony, which supposed to have 9 ring, but it gives a good distance, good intermediate, but unfortunately less near. Now, that's what's present in the published study, comparing to the bifocal and trifocal. Now, the second is the hybrid multifocal refractive. There's two types. The bifocal lens, it's not almost used, so that's why I will skip it. The other one is the new type refractive EDOF hybrid IOL involving central aspheric element, EDOF, surrounded by an outer refractive ring. That will be in the coming diagram. It's the Lucidus. Is a single piece foldable multi-zone refractive aspheric with a 360 square edge design and design with a closed loop haptics. The lens has 6 millimeter optical diameter and total diameter of either 10.8 or 12.4. It's made of hydrophilic, and this is one of the drop-up of this lens, the only one that's considered in all the published study, not with us personally, with a 26% water content. Now, this is the diagram for all, and I need to concentrate on the Lucidus. Now, if we can see that Lucidus use on the left up, use a technology that having central, reducing the sphere content, adding to or compensating this reduction in sphere to by the EDOF technology, by the negative wavefront. That can compensate to reduce the photopsia at night. But in addition, it gives acceptable for me personally near vision and excellent intermediate with excellent distance vision, with a remarkable, with me at least personally, that's my personal user for this lens, more than 30 or 40 lens I used. And surprisingly that I'm not hearing any complaint from any one of them about the photopsia. But few things related the near compensate with it, and that's what we will see in it. Now, just to compare between 3 issues. The sphere, here we are using hybrid refractive and hybrid, the upper above one, and the lower one, right, is the hybrid diffractive EDOF, and the left one is only the spherical EDOF, spherical multifocal. We can see that the spherical EDOF can create a continuous extended depth in a way that the patient can have reducing the gap in between the distance and the intermediate, and a good, at least acceptable near vision in a way that whole distance between the far and the intermediate and the near, it's reduced. So it's widening the field of, widening the depth of field. The depth of field is when person looking to the three objects in front of him, and those three in different levels. That in a monofocal, he will see only one object according to the focusing. That definitely he will not be able to see the intermediate and the near. The distance have excellent issues for him. With the others, he will have some confusion in between the distance. With the diffractive, with hybrid diffractive, he will have some confusion, some disturbance of the quality of vision in between the intermediate and far, and intermediate and near. But with the spherical, hybrid spherical, that confusion or that disturbance of the quality, or that effect of the quality of the vision, will be reduced comparing to the other kind of hybrid diffractive, or hybrid or only diffractive. Now, if we'll go to that lens, and in certain study, they show that even tilt of this lens, it will affect some of the near add, but it will not affect the quality of the distance vision. As Dr. Mahipal, I'm sorry that maybe I'm not pronouncing the name in a right way, so I apologize for that. Now, the last one is the hybrid multifocal refractive diffractive, and the important example that present in our site is the Synergy from Technis. This lens, employing a hybrid design, it employs 3 elements: refractive, 6 millimeter diameter, element 3.5 millimeter diameter, and centrally aspheric element 1 millimeter in diameter, hoping that it will add some to the near comparing to the Symphony. Till now, we don't have any study comparing Synergy from the same company, Technis, Synergy, and the Symphony. Symphony was pure diffractive, means that diffractive with add of the EDOF in the center. Synergy is the combination of diffractive, refractive, and with the add of the EDOF in the center. They aim here in two parts. First of all, to enhance the near vision by adding apodizing diffractive, and reducing the photopsia by reducing the add of the near from sphere to the EDOF. Means that from a sphere to the spherical abrasion. And that's the diagram of the lens, where it's very clear. In the posterior we have diffractive, in the interior we have central sphere and aspheric element, and in the periphery we have all spherical. Now, conclusion. I'm very sorry, maybe I'm late. EDOF lens should be used as a monofocal lens, pure EDOF lens, with minor improvement for near vision. They can be expected to provide bad quality of near vision, whereas intermediate vision can be adequate. For multifocal hybrid IOL, one can reduce the quality of near vision, but keeping intermediate vision the same quality of retinal image. But at the same time, you can decrease the halos and the glare. So this is probably for conservative indication. If a patient requires good near vision with an IOL, we believe, as all the studies that reviewed for this presentation, that he should receive a multifocal lens, a refractive and diffractive model, whatever, making the choice depend on the patient profile and perfect examination. Now, at the end, the choose of the lens is depend, as Dr. Ala said, after all examinations, especially the corneal high order abrasions and angle of kappa and alpha, excluding those from having any issues that reducing the quality of vision, even with the EDOF. So EDOF, it's not a lens that we can use it in those having high or bad cornea or high order abrasion. In my opinion and in my practice, I'm using the Lucidus now more than the diffractive physio, especially for those that they are refusing to have a halos or photopsia at night. Great, thanks. And I'm very sorry to be late.
Thank you very much, Dr. Safwan, for this new information about EDOF. I think we need to go directly because we are almost very late. Then we have discussion at the end, if there is a time, for Dr. Khalid Al-Arfaj, and he is going to talk about IOL in irregular cornea, post-LASIK in keratoconus. Dr. Khalid, the mic with you.
Thank you so much, Dr. Muhammad, for inviting me in this meeting. Do you see my?
Yes, it's very clear. Yeah, but yes, go ahead.
So we are a little bit late for the schedule, so I will try my best to summarize what I want to deliver, and this coming maybe 10 to 15 minutes. I'll be talking about the IOL calculation and IOL in irregular corneal. As other speakers, the expectations of our patients nowadays is really high, and we need to make sure that we can meet their expectation, try definitely to under promise and over deliver for those patients to satisfy them. And very important, and optimized cataract surgery require an accurate IOL power calculation. Nowadays, we have very good actually IOL calculators like the Zeiss IOL Master 700 that it uses the swept source optical coherence tomography, and we have LensStar 900 that used an optical low coherence reflectometry, and the other one is the TOMI, and it used also the same as Zeiss IOL Master 700. It used swept source optical coherence tomography. So we need to choose the best IOL calculator in order to have a very important, IOL power. To achieve an excellence, you don't need only to have an experienced surgeon and very quick surgeon. You need definitely to have a very important IOL calculator that can predict and give you the chance to have the best IOL can be implanted. Formulas very quickly. We have the historical refraction method, and we have regression method, we have vergence, we have artificial intelligence and ray tracing, like these lenses, and I will talk about it very quickly about it. The first generation was obsolete, and like the Fedorov and Pinkhurst. The second generation is SRK and SRK2. It uses two variables, and nowadays I will just to mention the Barrett, that this is one of the very important IOL formula that helped a lot of surgeons, as Dr. Ala said. And this was one of the very important and very good formula can be used for the premium lenses, especially. It uses multiple variables like the K reading, the axial length, AC depth, white to white, and even the lens thickness. The seventh generation, it uses the pattern recognition and artificial intelligence, and we'll talk very quickly about it. That's Hill, RBS, and Lattice lenses. And this is the accuracy range of commonly used formulas by axial length. We know the Holiday, Hofer can be used in short eyes, and we have SRKT can be used for the long eyes. And we see in the lastly, the Barrett and Hill RBF was having very high accuracy level. So if you concentrate on the Barrett Universal 2 formula, it has an accurate for eyes regardless of axial length. It uses proper K index. It has an A constant and for SRKT, and this optical constant, and it has mandatory variables. This is the axial length, K reading, optical AC depth, and refraction. And we have the optional. It uses also optional variables like the lens thickness and white to white. Optical biometer use this in LensStar and IOL Master. and there is no need to modify axial length. Can be used for applanation A scan. This is a very quick article about it compares intraocular lens power formulas accuracy, and it concluded this lens, the Barrett, has a very good accuracy, and by all means in the long eyes. So it has a very high accuracy rate. The Hill RBF, that is the uses the artificial intelligence radial basis function. It is an advanced self-validating method for IOL power selection, employing pattern recognition, as I mentioned, and sophisticated data interpolation. And I have the chance to use it. Actually, it has very nice also pointing the iris barycenter, that is the angle kappa. And we need, if you are interested to have the premium lenses, you need to have this angle kappa less than 0.4 to have an optical or optimized results. Now we will talk about the irregular corneas, and we have the sources of inaccuracy of case like dry eye disease, blepharitis, anterior basement membrane dystrophy, pterygia, cornea scar, keratoconus, even and Salzmann nodule degeneration can affect very much the accuracy of case, and the consequence we will have a wrong eye calculation if you have some of these diseases in the eye. What's problem with the irregular cornea? It violates the assumption that allow the IOL power calculation based on the K values, as these corneas can show high levels of high order aberrations. So it has very it affects the IOL calculation very much. And the anterior to posterior corneal curvature is abnormal in these cases. So we cannot apply the formula very well, and we need to be very careful in obtaining the IOL power. So you need to look at the ocular surface at the beginning and treat these cases before finalizing your measurements, like the pterygium or Salzmann nodule, and then you can repeat the measurement after you treat these ocular surface diseases. For like epithelial defect or anterior basement dystrophy, like the epithelial defect with the bully or irregularity in the corneal surface, you need to treat before you do the IOL measurement. We know that many of our patients, and about almost 80% of all patients that's having cataract, they have some sort of pre-existing dry eye. So you need to take care of this and treat it as much as you can before you take the IOL measurement. And this is one of the interesting cases of my cases. This is one of the cases of dry eye patients. After treatment, you see almost 1 diopter change in the IOL calculator after treatment of the dry eye. If you have an astigmatism, look at the source of the astigmatism and do the multiple technology to measure the astigmatism. Make sure they all agree, like the pentacam, the refraction, the autoref, and even the subjective refraction. See the glasses. You need to make sure these astigmatism agree, and you need to make sure this astigmatism is regular in order to make sure, like doing toric or not to do toric lenses. In examination, pitfalls, you need to measure both eyes. You need to know the contact lens use, previous refractive surgery, and to use the topography in order to make sure that these K readings are true case. For the axial length also, you need to do both eyes, and you need multiple readings to make the accuracy, high accuracy. And in the axial length, we know normal eyes 1 millimeter will error will end up with 2.5 to 3 diopter of surprise, and in short eye 1 millimeter might end up with a 7.5 diopter surprise. In K readings, we know that 1 diopter might end up with a 1 diopter of surprise. And this is the corneal topography showing very irregular cornea. I know just to show you this literature review about the IOL calculation in keratoconus, and this is the conclusion. And then you know the main problem in keratoconus patients is unreliable biometric measurement. So we have the steep keratometric values in these eyes and might result in selection of low power IOL. Presence of this low power might yield an extreme post-operative hyperopia and might necessitate the exchange of this IOL. So in cases of keratoplasty will be needed in the future, you might use the method of contact lens fitting in order to select the proper IOL. The axial length measurement may have better repeatability than the keratometry. And in order to have an IOL calculation in mild keratoconus, you can use SRK2 formula, and that might end up with a good predictable IOL. But for the moderate or severe keratoconus, the literature does not show a specific formula that can help a lot in very severe keratoconus. This just show you the cataract surgery in corneal scar patients, and they suggest to do definitely the monofocal lenses. In most of the cases of corneal scarring, the keratoconus, post-refractive surgery, post-RK, all suggestion and advice and recommendation is to use monofocal lenses. A very quick also literature view about the intraocular lens calculation in previous corneal refractive surgery, just to show you a lot of formulas suggested, and many of these has a range of accuracy from 50 up to 70% of these methods to have less than 1.5 diopter post-operative optical or refraction rate. This is using the hysterical method, and this is without hysterical method. And we know that Barrett and Hagias specifically, and other also like ray tracing, has the highest accuracy level. So if you want to suggest, we can use the Hagias L or Barrett or ray tracing from Olsen. We have the highest post-operative refraction, post-refractive surgery. Last 3-4 slides, I will show you the very promising, hopefully, the IOLs from AcuFocus. It has a very forgiving IOL. It might eliminate most of the high order aberrations and help the patient to see well, even for the near vision. I think this lens was touched up by Dr. Safwan previously in his talk. So, and major advantages of this lens is to correct the irregularity, and it has a sharp focus and suits patients with keratoconus, corneal scarring, and post-RK surgery, and even some post-refractive surgery can be used in this lens. Extra focus, also another lens, could be placed in the sulcus, it's a piggy bag, and it has 1.3 millimeter aperture, and it helps to decrease also the high order aberration very much, and helps even the near vision. Overall diameter is almost 14, and could be inserted into 2 millimeter. So at the end, this is one of the clinical IOLs of the extra focus. We can conclude that understanding the cornea role in IOL power calculation is very important to avoid errors when the cornea shape is abnormal. The newer formula can avoid most of these common errors, and we know, as Dr. Mahibal stated, in the future, it's a long way. It is journey of IOLs has been long, and it is upward. I like that statement, and we know the cataract series transformed from the cataract cure to spectacle independence nowadays, and to achieve the excellence, you need an accurate IOL power calculation. You need to use the proper formula for specific corneal diseases or of even premium lenses, and know about the Barrett lenses, and know about the 7th generation pattern recognition based IOL calculations like the Hill, RB, and Ladis formula. Thank you so much.
Thank you very much, Dr. Khalid. I know you go very fast in your talks, so because of the time, but it was an excellent and very clear, and you go directly to the point. So we are thanks you for this very excellent presentation. We will have only 5 minutes because we are very late, and before that, we can ask the management event to put the please the link for certificate of attendance in the chat, so anyone can just get his certificate. So now we will open the discussions, and if there is any question from the panelists, Dr. Usama and Dr. Khalid and Dr. Yahya, if he's still here with us. I think we are having only Dr. Khalid and Dr. Usama. We are having Dr. also Khalid Arfaj, Dr. Brasan.
Question for Dr. Safwan.
Yeah.
Do you usually aim for a little bit of myopia using the EDOF lenses, or you target emetropia?
Now that's you need to specify which EDOF that I'm using. EDOF trifocal, EDOF
trifocal,
refractive.
No, EDOF trifocal, of course.
Yes. Okay. So here we need to be more specific. EDOF diffractive or EDOF spheric. For example, Symphony or Lucidus or
the diffractive.
Diffractive. So if we will go to the diffractive, I will aim emetrop. Emetrop. If you will go to spheric, EDOF spheric, I will aim plus minus 0.25, not micro monovision. The issues is that
for the monofocal, you need to aim for myopia, a little of myopia with the EDOF monofocal.
EDOF monofocal. So it means that one eye you did it as a monofocal and the other eye EDOF, or
like the visual, they have the monofocal EDOF lenses, I think. I didn't.
Here you are talking about pure EDOF.
Yeah.
Physio, pure EDOF, isopure. Here we need to go through and do micro monovision, because EDOF isopure is plus 1.5 add, and when you add 1.5, the patient will be a little bit happy with the intermediate. So if you will add one eye minus 0.25, minus 0.5, the patient will have an excellent near vision. That's right. The quality of distance vision will be affected a little bit. The 6.6 pure quality of vision at 6.6, it will be affected. But if you will measure that quality of vision on distance 6.6, the patient will not complaining when he has the pure EDOF, because he will not lose a lot of contrast of sensitivity because of the spherical abrasion. If you compare it to diffractive and you will do a micro monovision, the contrast of sensitivity that he will lose it because of the diffraction, adding to the contrast of sensitivity that he will use it because of the micro monovision, it will affect the distance vision. That's why in diffractive hybrid, I will target emetrop. In pure EDOF, I can target micro monovision without affecting the distance vision.
Okay, thank you.
Dr. Usama?
Thank you, Dr. Safwan, Dr. Khalid. Dr. Safwan, which one using isopure and Lucidus? Which one of your patient?
That's a very, very, very good question, because this is the aim. This is what we are using. Now, patient having total, let me just talk on this fundamental issues, that patient having total corneal high order abrasions of 0.5, he's not suitable, or above 0.5, he's not suitable for trifocality. So in this patient, I will try to convince this patient to use isopure or pure EDOF, whether it is isopure or iHands or Vivity. If this patient having less than 0.5, then high order abrasion, especially the spherical abrasion, then I can use for example, the two issues in front of me. If that patient doesn't need to have the halos at all at night, I will go to the usual diffractive trifocal. If this patient accepts some halos, if it doesn't need to have any halos, so I will go to EDOF spheric. If it accept some halos, then I will go to diffractive trifocal. So according to the patient's requirement, patient acceptance, and the corneal examination. In my practice, high order abrasions and angle of kappa and alpha is a crucial for my work. Definitely apart from the others.
Khalid, I think maybe he's having a comment about this one.
Yes, Mike.
As Khalid Arfaj.
Excuse me, I have very limited actually experience with the EDOF. I used Lucidus for 6 or 7 patients, and most of these patients actually are okay, but they are not really satisfied with their near vision. Okay. So I mean, they have, I mean, a good intermediate as you mentioned, but the near vision, as mentioned even Dr. Ala previously, the defocus curve is really compromised in their near vision. So I didn't much offer the patients nowadays, unless I explain that very much to them, the Lucidus. Most of the patients in our market, they are in favor of having very optimized near vision. Okay. And we don't have really a lens other than the trifocal lens that can provide this quality near vision for them. So I apologize that I have very limited experience.
Okay. But Khalid, just one comment for Dr. Khalid. You are talking about in a very good way, and let me ask you a few questions for those patients that you did. What was the total high order abrasions for them?
Most of the premium lenses we are excluded for a high order abrasions. Okay. They have very nice, I mean, corneas without much of irregular.
With an accepted limit. So what was the refraction post-op?
Post-op, I mean, it's as usual. We aim for metropia, as you mentioned, and I mean, some of them, they are having some 0.2 or 0.3 even myopia.
Myopia, and still they are not satisfied.
As compared, I never explanted any of these lenses. Okay. These lenses are really good, but as compared with the trifocal. Can you?
Yeah.
Safan is interrupted. Your voice was interrupted.
I'm very sorry. That's why I explained to Dr. Osama that the patient that insists to have near vision and he's eligible for trifocality, I will go to trifocality. The patient that he has an eligibility, but he can accept some of the halos, I will go to the trifocality. But the patient that can accept a reading in a good intermediate and a reading on 40 centimeter and reading only the messages of the phone, and that I can go to the spherical EDOF with a minor, means not micro, and a minus 0.25. That's my target for the refraction, and their vision is excellent for the near.
I think we are behind the time. If we are having, we need a very fast response. Okay, if there is any comment or questions, Dr. Osama, Dr. Khalid Ayyad, Dr. Khalid.
Just one question. Anybody is experienced with AcuFocus, the pinhole IOL?
I don't think it's available here in the market. It's not available. In Jordan, we don't have it. I'm not sure.
Osama? Do you have an experience, Osama?
I haven't used it. But it's good lenses in some cases, I think.
Yeah. I saw a few cases that done. Yes, I saw a few cases that done in one hospital here in UAE, and well, the patient experience is in this way. That's right. Vision is improved than their glasses because they had keratoconus, but still they are suffering from a distance vision. Now, intermediate, it's good. Near, it's poor. Distance also, it's poor. So
thank you.
It's one case that I saw from one of our surgeons.
Okay. Okay. I think we came to the end of this session. It was very long, even though we don't have, we missed Dr. Elizabeth. She didn't give about tutorial. She apologized for that. For all the attendees, the link is available on the chat. Just open the chat, you will see the link. Just click on the link and put your information before we close the session so you can get the attendance certificate. I have one question for all of you, but a very short yes or no number or percentage. What is the percentage of now monofocal in comparison to multifocal in your experience? I will start with Dr. Khalid. For those, they are eligible for multifocal.
I think it's not more than 10 or 15%.
Dr. Khalid Arfaj?
30 to 40% nowadays.
Now 30 to 40% multifocal.
Yes, trifocal.
Okay. Yeah, trifocal. Yeah, we are saying multi, I mean trifocal. Okay. Dr. Safan?
Well, I thought Dr. Khalid, he said that monofocal 10%.
Yeah, Khalid, Safan, what is your percentage? Your percentage.
Percentage for trifocal.
Yeah, trifocal in comparison to monofocal, whatever you want.
70%.
70% trifocal.
Yes, eligible for trifocal, 70% of them.
And Khalid, I think you are saying trifocal is 10%, right?
10 to 15%, yeah.
Okay, Dr. Usama?
What is eligible, maybe 70%, but what I'm using.
Yes, what I'm, this is my question.
Yes, what I'm using. Patients, maybe.
No, Usama, can you repeat? Usama, we're not hearing you. I think we missed Usama.
Yeah.
Okay, Dr. Brasan, you are still there?
He's
mute.
Mute.
Prashant, you are mute.
Okay, I think maybe he is not listening to us. Anyway, I would like to thank you all for this very interesting and very nice webinar, and with very eminent speaker. Your presentation was very excellent. All of you, thank you all. I think we need more and more, but we are willing only to put a highlighting about this subject. But each of these, presentation, it needs a special webinar by itself. So thank you very much. Thanks for the sponsoring company Allergan. Thanks for our management event, and thanks for all attendees. And good night, and see you inshallah in the next week with a very nice and well organized webinar about the 8, 6, 7, and 8 series of cataract. It will be about the pediatric cataract and also the use of femto in femto assisted cataract next week inshallah. Thank you very much and have a nice weekend. And